So my name is Doris Hansen from Moffitt Cancer Center. Today we're at Chicago at ASCO. I'll be presenting on safety and efficacy of standard of care ciltacabtagene autoleucel for relapsed refractory multiple myeloma. This was a multi-center retrospective study of patients planned for standard of care ciltacabtagene autoleucel. We had 22% out of specification rate and 16% of patients who received alternative lymphodepletion. Overall, 153 patients were apheresed and 143 patients were infused. 6 of those patients who did not make it to infusion had experienced disease progression and death. 57% would have been deemed ineligible for clinical trial inclusion. Overall, we did treat a patient population with very aggressive disease biology like high-risk cytogenetics, extramedullary disease, plasma cell leukemia. Safety was very similar to the clinical trial with similar CRS and ICANS rate. Delayed neurologic toxicity occurred in 12% of patients. 1% experienced Parkinsonisms. The rest, or the majority, had Bell's palsy or cranial nerve palsy, and there were some others like dysautonomia, polyneuropathy, and PML. 2 patients died of delayed neurologic toxicity. 35% recovered from this delayed neurotoxicity with steroids and IVIG. Non-relapse mortality was 10%. Regarding response rates, the best overall response rate with a median follow-up of 6 months was 89%, with 56% of patients achieving a complete response or better. We also reported on the intention to treat population. Regarding 6-month PFS and OS estimates, those were 79% and 84%, and 67% and 79% for 12 months in the intention to treat population. We did do multivariable analysis for efficacy, which demonstrated that high-risk cytogenetics was associated with inferior responses as well as survival to include progression-free and overall survival. It did not appear that alternative lymphodepletion or prior BCMA impacted outcomes, which is a bit different than what we've seen before. Although I do believe we've learned from our experience with less BCMA exposure and a longer timing of more than 6 months from prior exposure to BCMA therapy. So overall, I'd say that this therapy is a good therapy for patients. We see favorable responses as high as 89% and even higher in the non-EAP flu-cy population, up to 94%. Delayed neurologic toxicity is 12%, non-relapse mortality is 10%, and patients can benefit from this treatment outside the confines of the clinical trial. Thanks very much.